meeting to order. Good afternoon, everyone. Apologies for starting a few minutes late. Welcome to the March 20th, 2024 Yolo County City of Davis 2x2 meeting. Just quickly note that for roll call, all members are present. Moving on to item 2, designation of chair for the day. Is everyone okay with that? All right. We'll go to item number 3, approval of the agenda. Any adjustments to the agenda? If not, can I get a motion to approve?
So moved.
Second. Okay, thank you. Motion by Chapman, second by Provenza. Any questions, comments, or discussion? Not hearing or seeing any. All those in favor? Aye.
Aye.
Any opposed? Any abstentions? Motion carries. Thank you. Actually, before we go ahead, I'd just love to turn it over to Supervisor Provenza for a quick introduction.
Yes, I would like to introduce Katie. Is this on?
Yeah, you gotta press it. Yeah.
Oh, now it's on, okay. I'd like to introduce Katie Caceres. She is a UC Davis student and my intern, one of my 2 interns for this quarter. She's in the environmental science program at UC Davis and is also environmental caucus chair of the Davis College Democrats. So welcome. She'll be assisting us this year.
Welcome, Katie. Back to, let's see, so item 4 on our agenda is approval of the November 8th, 2023 minutes. Any changes or adjustments to the minutes of November 8th, 2023 meeting? No. All right, is there a motion to approve?
So moved.
A motion by Provenza. Second by Partita. Any questions, comments, or discussion? Not seeing or hearing any. All those in favor? Aye.
Aye.
Any opposed? Any abstentions? Motion carries unanimously. Thank you. Moving to item 5, public comment. This is a time for members of the public to address the 2x2 on items which are not listed on today's agenda, or if you are unable to stay for the full duration of the meeting. Not seeing too many takers for public comment today. We will then, if someone from the public does come and want to make public comment, we can always go back to that. Item 6, moving along, discussion items, crisis now update. We are fortunate to have Yolo County HHSA Director Nolan Sullivan with us today for this presentation. Nolan, thanks so much.
Thank you so much for your time. And I've got with me today the Health and Human Services Agency Assistant Director, Carleen Jakowski, who's also the Mental Health Director, to assist with today's presentation. So very excited to be here. There's a couple handouts in front of each one of you. One is the slide deck, and one is also a budget doc that we'll review at the end of the presentation. And as an aside, not related to Crisis Now, I've also given you an updated copy of our YOLO by the numbers that shows all of the social service program utilization across the county and in the city, specifically in Davis as well, just for your viewing pleasure later. So we will start off. I have some really good news today, I hope, in regards to Crisis Now. I know we've been before this body several times and presented some delays and slowdowns and obstacles. I think today the tone of the presentation is the opposite of that. We actually have some progress, some next steps, and most importantly, we have a specific ask that we'll come to at the end of the presentation today. So we'll move along through this pretty quickly here. I'm not going to spend a whole lot of time on the background of the slide. I think everyone's pretty familiar with what Crisis Now is, what it has been, kind of where it goes. Way back when, in 2020, we participated in a work group that really kind of put the agency and the county on a path to creating a new crisis system of care to assist with those in crisis across the county. The national recognized model was identified as a best practice that we wanted to implement. And at the time, the Health and Human Services Agency Director and leadership decided to engage on a 3-year pilot program. So we start the planning and all the processing to get us into that 3-year pilot. Early last year, myself and Carleen Jakowski, who are relatively new to our positions, although it's been a year or 2 now, really took a deep look at the existing plan, and financially, frankly, it just didn't work. The amount of dollars we were going to sink into physical infrastructure for a 3-year pilot was just unsustainable, and then the ongoing revenues needed to maintain that pilot just didn't make sense. So it's hard to believe that just about a year ago, we had kind of re-engineered the plan in totality. We have coined it Crisis Now 2.0. I know we need a much more creative name, and we'll work on that later. But we've been working hard on this new revised plan and actually getting some stuff done over the last 11 months or so. So the next couple slides, we'll go to the next slide here. We're going to show you what Crisis Now is. And this slide is very simple, but I think it actually really elegantly explains what Crisis Now is. So when you're thinking of Crisis Now, your constituents are asking, or your city staff are asking, what is Crisis Now? It is a big, confusing, convoluted system, but the way we're describing it really is the countywide fourth emergency system of response, right? So if you look on your far left there, you have paramedics, you've got ambulance services, you've got dispatch, you've got your emergency department and hospitals. That's how you deal with your medical emergencies across the county. On the law enforcement side, you have your police response, so you've got your police officers, you've got 24/7 police dispatch, you've got police patrols, and then you have the county jail or lockup in the local police departments, right? You've got that system of care to respond to those law enforcement emergencies. Fire response, if you've got a fire, a wildfire, a house fire, et cetera, we have a team of firefighters out of the cities or in the unincorporated. They have 24/7 fire dispatch. Obviously, they have their fire stations and their fire teams and fire trucks. We can respond to fires across the county. What the county lacked and what a lot of municipalities are lacking is a crisis response, right? None of these three existing tools really dealt with mental health crisis. None of these three tools are really the right tool for the job. And so again, we're creating a whole new system of care. So with this new system of care, we'll have a team of mobile crisis responders. That's the someone to call or the someone to respond. We'll have a 24/7, and as I don't want to say we have, as of today, a 24/7 high-tech call center that's taking these mental health calls with clinicians on the other end of the phone line. We'll have mobile crisis teams, which we have some of today in our police departments, but we'll have those 24/7, which we also have to some extent today, and we'll talk about that a little bit. And then the last piece that we don't have just yet is that where to go, right? And that's the receiving center that includes recovery and sobering. That is the last step in the process. So again, building a whole continuum of care. I know it's taken us some time. I know folks are ready for us to move forward. But when you're building something that's big and complicated, it takes some time. So that's a great way to really kind of explain what Crisis Now is doing in totality. The next slide here, you guys have seen this slide many a times. And again, I think the one thing I want you to remember from this slide is it's a number to call, a person to respond, and a place to go during a crisis 24/7. That's exactly what we're building. That's what these steps encounter. And again, that comprises of three main components. That is the Access and Crisis Call Center. That's the co-responders, that's the people that respond, and then that is the receiving center and the sobering center, in addition to the 24-hour beds, which we'll talk about in just a second. So that is the whole system of care that we've been building out and that we're moving towards. Next slide. This is the really exciting part. I know there's been a lot of delays, and I know there's been a lot of anxiety about getting this project done and moving forward. We're really happy to report that we actually have almost the first 4 phases of the project complete. So phase 1, obviously planning. Just 11 months ago, we sort of re-engineered the entire plan, ran that by our board, ran that by our city partners, and we started launching the 2.0 initiative. We have the Crisis Now contract done for the beds. The facility has been identified. The contract is in. We just got through contract negotiations. In fact, the Yolo County Board just ratified that contract a meeting or two back. So that is done, signed and sealed and delivered. That is in place today, which we're very proud about. The high-tech call center, actually the last board meeting also approved this contract. So we're done with contract negotiations. We have a brand new vendor that we're very excited about, WellSpace out of Sacramento. They're phenomenal. They are now running a 24/7 call center. They will also be running the 988 regional call center as well as the suicide hotline. And we are actually switching over from our current vendor to our new vendor as of the end of this month. Right?
Yes, at the very end of this month, we'll transition the call center from our current operator to WellSpace, and the vision over the next several months is that full integration of the 988 call center with our own access and crisis and the 24-hour mobile response as well.
So that's up and running, and again, that yellow will turn to green here very quickly, but that service is up and running. The contract is ratified. We're off and moving there. Last but not least, in terms of the progress update, is we have our 24/7 mobile crisis pilot in the first iteration, I will say, officially launched. So as of January 1st, across Yolo County, we had 24/7 mobile crisis response for Medi-Cal recipients. So you could call 24/7. We are standing up a temporary pilot with AMR serving as the crisis co-responder. So not your traditional ambulance. Think about a care car and a crisis responder and a Yolo County Health and Human Services clinician on the phone line triaging those mental health crisis emergencies. So this was our kind of first pass to get that stood up. In addition to that, we have 8 crisis co-responders that are embedded in police departments working various hours throughout the day, some even on Saturdays and Sundays that are covering the daytime coverage. So we literally have 24/7 coverage around the clock now. We will continue that coverage, and as we build Crisis Now, we'll integrate more and more pieces of that 24/7 coverage through the Crisis Now Receiving Center hub. So more to come on that, but as of January 1st, in Yolo County, we effectively have someone to respond to crisis, someone to answer the phone for a crisis call 24/7, which is very impressive. And I do want to thank Carly and her team for that tremendously heavy lift. It's been a bit of a rocky road. We've done a lot of work with Chief Pytel. There were some bugs that we had to work out, and so we made a couple of workarounds to make it work for now, but we're getting better and better and better each and every month. And then if you look up top there, there's a little asterisk and city and partner funding requests. That's exactly where we're at today. At the end of today's presentation, we will talk about the actual budget for the next steps here and where we're going to head, specifically about phase 5, which is the crisis receiving chairs. That is the facility the county is building out of the JDF property. And then phase 6, which we'll think about a year or two down the road, is again assessing the evaluation of this pilot. Again, this is a 3-year pilot. That was the original goal. It's not ongoing, it's not permanent. The idea is to begin assessment as soon as we launch, continue that evaluation and assessment, bring that back to our board, bring that back to this council and see what actually happened, what worked, what didn't work, and wonder if we want to continue past the 3-year evaluation period. Next slide. There's a ton more detail here on the major components. I won't go too far into the weeds unless folks want me to, but again, the high-tech call center, we just talked about that. The RFQ was signed, sealed, and delivered last week. New vendor comes on board next month, which we're very excited about. Short-term crisis beds, the contract was signed a couple board meetings back. We've been in the contract negotiation period. That is now up and running and fully functional. We're very happy about that. The 24/7 crisis staffing and co-responders, again, as of January 2nd, we have 24/7 response. We continue to work with our police chief partners on their crisis intervention technicians that are embedded in the police departments. In fact, we attend the LEAC meeting tomorrow, which is the Local Law Enforcement Agency Coordinating Commission. We'll be meeting with all the police chiefs as well as the sheriff, the DA, and other law enforcement partners to share pretty much this exact same presentation and take their feedback and concerns. We also have a meeting next week or the week after with the fire chiefs councils. There's 2 separate fire chief councils, so we'll be meeting with all the fire chiefs and the EMS professionals to have the same conversation and update. So we're kind of moving through those processes. Phase 5 and 6. Phase 6, again, is the evaluation period, which we'll talk about at a later date. Phase 5 is the biggie. That's really what's holding the project up. That is the receiving center that is 24/7 for crisis or sobering needs. We will have 6 to 8 receiving chairs in Woodland. And we're actively working on the construction cycle for that particular building. That is really what's slowing things down, is just the construction time frame. But outside of that, everything else is on track and moving forward. We'll talk about the construction time frame in just a second. We are identifying a possible subcontract for a few chairs in Sacramento that would allow Davis or West Sacramento to access those chairs since you're kind of centrally located on the causeway. And that's something we'll simultaneously be looking at. So in addition to the facility in Woodland, we may have a chair or 2 at a facility in Sacramento that's very close that will allow us to have sort of triangulated coverage across the county. Next slide. This is the big money slide here. So again, the one thing I want to express is that the county has identified funding for the bulk of crisis now so far. So we've identified funding for short-term crisis beds. We're not asking for city contributions. We're not asking for partner contributions. We have identified all of the revenues needed for the high-tech call center, which you can see there is $4.2 million. We're not asking for contributions for that as well. We have those ongoing projects, we've got that locked in. The crisis co-responders, for the most part, the cities are paying about 1/3 of the cost of those FTEs. So we have an MOU with your police departments where they're paying about 1/3 of the total fully loaded cost for those employees. The county is putting the other 2/3 of that bill, as well as all of the supervision, overhead, et cetera, et cetera. So that is fully covered with some contribution from our city partners. The receiving center is where we have the big gap. And so we've got about a $4.5 million hole in the receiving center. That's what we're trying to fill. And we'll talk about how we plan on filling that later. This was the conversation that was initiated by my predecessor years ago about having the cities kind of partner and help us lift up a chunk of the project. And we'll talk about that in detail in just one second. And then this is the construction schedule for the receiving center. And this is really what's slowing things down at this point. Again, I'm sure the city has had many construction projects lately. Everything is coming in over bid. Everything is coming in longer than it should. And unfortunately, crisis now is no different. So we're looking at a construction schedule here that puts us into probably summer of 2025. The CAO and the General Services Director have assured me we can probably trim some time off that by a couple of months. But we are doing our absolute best to get that facility open because that will complete kind of the total package of crisis now.
I'll just add there that our team is meeting bi-weekly with the contractor that's working on the architecture design process and our general services team, and we're hoping with that regularity of the meetings and meeting so frequently that we'll be able to trim some of the time off. We certainly feel a sense of urgency to get the facility up and running, and so we are hopeful that the extra effort that we're putting in now will help to shorten the timeline, but certainly that's still yet to be seen.
just to add, thanks, Carlene. Pardo Pinedo, CAO. Nice to see everybody. We're clearing the deck, so to speak, with general services so that other projects launch to the A&E phase, so that this one can get more of our attention. So I agree with Nola, and I think we're going to be able to shave some time off of that. And we have that commitment from Ryan Pistakini as well, our GSD director.
Okay, and then before we go to our last slide, I didn't actually bring a handout or to project this because it's so teeny and it's probably teeny even on the handout. But if you refer to this document here, it's a single sheet of Excel spreadsheet. Again, the top section is what we're referring to. If you look at the third column from the left, you'll see Davis's requested contribution. So again, we're trying to close a $4.5 million gap, and that is over essentially 4 fiscal years. You can see there what contribution we're requesting from each of the different cities, as well as our hospital partners, so Dignity and Sutter there on the right. UC Davis is a bit of a question mark. I'm hoping we can discuss that a little bit today as well. But the way we came up with that was essentially using the population ratios below that. If you look in the square below, you'll see population data, and that's essentially how we came up with the amount to close the gap. We have met with all of the city managers. They've seen this document. We've talked about kind of the request and the ask. We've gone to the Woodland 2x2 and presented the same information so far. You're our second 2x2, and we'll be going to the West Sacramento 2x2 at some point in time to present the same information. My initial understanding from early discussions is that ARP is probably the desired funding source for a lot of this, so we're also working with our Department of Finance team when and if your councils are ready to engage in the contracting process to make sure we meet those expenditure deadlines and requirements by 2024 and the encumbrance by 2026. So that's kind of where we're at. So as you can see, what we're requesting from the City of Davis would be a $930,000 total contribution. Again, this is our first pass, our first request, and we break that down over 3 fiscal years, which comes down to about $310 per fiscal year. And again, this is the first time we put numbers out there, but that is kind of where we're at. We are having similar conversations, like I said, with the other cities. We have confirmed the contributions from Dignity and Sutter, although we will probably be asking them for some more at some point in time, but that is where we're at today. We've sort of struggled to figure out how to engage with UC Davis, but that's something maybe we can talk about together as a team today, but that is pretty much where we're at. So with that, I will stop talking and leave it for questions, but again, we are looking to close a $4.5 million gap with contributions from our partners, and that only is for the receiving center. We're not asking for any funding for any of the other components of Crisis Now. That's solely the receiving center. And we'll open it up for questions.
Great, thank you. Appreciate that overview and update. Start off, we'll go back to members of the 2x2 for questions or from staff, either. Anybody?
So my first question is about the receiving center. So it looks like this is an existing building already. And so the conversations that you're having with the architect is around just remodeling that building, because you're not building a whole new building.
That's right. Yeah, it's an existing building. And so the work is really around ensuring that the internal flow and the structure internally really meets the needs. As you can imagine, there's quite a lot of criteria that we're needing to consider around preventing suicide and preventing self-harm, and so a lot of sort of special precautions being taken around things related to the bathroom and, you know, and the way that the building layout is, including where cameras may be and things like that. So it's really around ensuring it's a bit of a box. So we do have a sort of a clean slate with offices going around. It formerly was the probation department's offices many years ago. And so we do have a bit of a clean slate, and but yes, it is around the internal structure. We made laundry facilities and showers and things like that that don't currently exist.
Okay.
Yes.
And then the calls for service currently, I know one of the big focuses of this was to divert people from using emergency rooms. Do you have any information, or because this has been in, how long have we been functioning?
So for the mobile, so we don't have the receiving center, right? So I think the true benefit of being able to truly divert from the ED, we won't fully see until we have an alternate location to bring folks to. However, with the 24-hour mobile crisis response, we've had about 50, a little over 50 mobile crisis contacts since the program implementation on January 2nd. Very slow ramp up the first couple of weeks, and we're seeing a lot more call volume now. We had 6 calls over the weekend. We have had some folks who did need to be placed on a 5150 hold and taken to the emergency department for placement, but we don't consider that to not be a success rate of the model because sometimes people will need that additional level of stabilization. So I think the true benefit to reducing overuse of the ED for people who are experiencing mental health symptoms, we'll see with the implementation of the receiving center, but we are already intervening in crises in the community, working to help stabilize folks and develop safety plans to prevent people from ending up in the emergency department, whether or not they're actually placed on a psychiatric hold and been hospitalized. So I certainly think we're seeing success so far. We've only had a few of our mobile crisis contacts result in needing to be transported to the ED on a 5150 hold, like less than a handful.
And then this idea of using AMR, I guess, with a counselor on call is new to me. I haven't heard about this.
It is a fairly new pilot. It's probably going to be relatively short term. It's very expensive. Oh, sorry. Thank you. It's a fairly new pilot. It's probably going to be relatively short term because it's very expensive. Part of the problem in a county unionized work environment is for us to mandate staff working 24/7. It's not as easy as it sounds. So we have to go through the whole meet and confer process, create new class specs. To really have a 24/7 operation for us, it's taking some HR infrastructure time. And so AMR has been a super gracious partner in helping us kind of work some of those angles out. I don't anticipate, unless we can find some significant cost savings or revenues, that will kind of continue that pilot going forward. But that's what we have at least now through the end of the fiscal year. And to Carlene's earlier point, that 50 calls is from January 2nd. And so again, that's 50 calls where a police officer or maybe an EMT would have showed up to a mental health call, which is great. And that's huge progress. Part of it too is we're not really advertising the service widely because we're working all the bugs out, so we don't want to overload the system. But we're already starting to see some immediate change, where in the past you might have had someone show up from law enforcement, and maybe that's not always the best case scenario. In at least 50 instances just since January 2nd, we've had actually a clinician, a crisis co-responder show up to triage those calls. So it is a temporary measure, and we do plan on making some changes to that.
Okay, because currently the co-responder is not 24/7. The clinicians that are working with the embedded in the police department, and I know that has been sort of a concern for us.
Yes, I can speak to that. So we currently have 1 co-responder embedded with the Davis Police Department. We did budget or plan for 2 additional FTEs of co-responders. One of those identified to being added to Davis at Chief Pitel's request. So we're working through that process now. So ideally, in the near future, we have 2 FTEs here. We won't ever have 24/7 coverage of co-responders. It's quite costly to have folks working those hours, especially for the call volume. So we did really consult with quite a lot of data as we were developing this model. And just as a reminder, the 24-hour coverage, while we think it's best practice and what we want community-wide, it is a requirement for Medi-Cal beneficiaries as of January 1st, and we are responsible to ensure that benefit as the mental health plan for Yolo County. So while this is specifically created for Medi-Cal beneficiaries, we are not screening anyone out based on their insurance status. So we are responding to mental health crises no matter what insurance the caller may have. And so our co-responder coverage countywide across all jurisdictions actually goes quite late until about 8 p.m. And as Nolan said, in some jurisdictions where we have 2, they work alternating schedules where we actually have Sunday to Saturday coverage because of their schedules. That is not the case here in Davis at this point, but certainly could be in the future with the addition of a second co-responder. So what we're really working on is the after hours coverage to ensure access. And Nolan stated accurately that we have our clinical staff on standby and they're responding via telehealth right now. That's while we're working out some safety concerns that were brought up by our unions. We are very close to resolving those, ensuring they have access to the same tools and resources that our co-responders have during those hours to the extent possible, vests, things like that. So we've obtained all of those items, and so we are confident that in the very near future, we'll have our clinicians also going out in person with AMR. So AMR would do the immediate in-person response because they'll be able to get there quickly, their staffing during those hours, and then we would have someone come out on call or on standby. And to Nolan's other point, we're working on a longer term model that's sustainable financially because it is cost prohibitive currently.
I think the last question that I had was around the ARP funds. We set aside ARP funds for this, correct?
Yes, the city council is actually one of the very first set-asides that the city council did a couple of years back, actually when then Councilmember Mayor Frericks was on the city council at the time, of course. The city council at the time, not knowing exactly what the need was going to be at the time, of course, the set-aside was for 1.17 million of ARP funds. And obviously we see that there's the ask is looking like it's honing in on around the 930 number. And so that's, but the 1.17 million was the original set-aside that the city council had made, knowing what we knew at the time.
I'll wait for my other questions.
Sure, yeah.
Mayor Chapman? Yeah.
Thank you, Nolan, and your team for being here and for continuing to work on this. Couple of quick questions. One is, on the handout, the paper that we have, it talks about the new law that took effect January 1st. What's required under that new state law versus what's going above and beyond that and what you're providing? What's the county required to do by state law versus what is in front of us here?
That's a great question. So what has actually changed is the Medi-Cal requirements. We're required to provide 24/7 mobile crisis response to Medi-Cal recipients only. So what I'm honing in on here is we are only compensated for Medi-Cal recipients. We are not compensated for folks that are uninsured. We're not compensated for folks that are privately insured. We have no mechanism today to bill privately insured. So obviously my crisis responder is not going to show up and say, hey Josh, show me your insurance card, or we're not going to serve you, right? So we're going to serve everybody. The interesting thing here is we have a tremendous funding gap for folks that actually have insurance because we don't have the ability to bill private insurance. So that kind of streamlining, and Carlene can kind of go into the weeds on that, but the big picture is we have to provide mobile crisis response for Medi-Cal recipients as of that January date. And as you can see from this document, Medi-Cal recipients in Yolo County, there's only 55,000 of them. So we are providing mobile crisis response for everybody, but we are only compensated on a per incident basis for Medi-Cal recipients that qualify.
And I'll just add that it is certainly in our long-term sights to work on our own internal infrastructure to bill private insurance, and just because you bill a private insurer for a service does not mean that they will pay you for that service. And so I know that the California Behavioral Health Directors Association is also doing quite a bit of advocacy at a state level around more stringent language, compelling commercial insurers to pay for these services that are required. So I think there are some long-term potential increases in revenue on the horizon, but not in the near future. But to Nolan's point, we feel compelled to provide this service to anyone. So the above and beyond is really the extension of serving the whole community. And then in terms of the plan you're seeing here, we are also not compelled to open a receiving center or a sobering center. That is not a requirement, even for Medi-Cal beneficiaries. So that's something that we've identified, I think, collectively as a gap in our crisis continuum in Yolo County, but no community is required to implement a receiving center. Having access to crisis residential beds is a level of care that's necessary for Medi-Cal beneficiaries, but we also serve folks with commercial insurance in our residential beds as well, and that is also not a requirement. So I would suggest that that is above and beyond too, and then certainly the co-responder model is not something that any community is compelled to do, but we have really great partnership with, of course, the City of Davis and our other city partners as well, and it's a very effective and well-received program.
Thank you. Yeah, and so then the funding gaps that are laid out here, that's inclusive of the gap that you would anticipate having after the 25% is billed and you receive those dollars?
Yeah. The gap actually might shrink a little bit depending on revenues, to be honest, we just don't know. So
Sure.
we're banking today on an estimated contract cost to have an operator operate the receiving center. We're also banking on all the facilities, infrastructure, and upgrade costs. So to Carlene's point, we are being fairly conservative in this budget, and the gap most likely might shrink a tad, but you also never know. We have a big influx of folks that are not Medi-Cal covered. Frankly, it could kind of break the budget, so the budget is pretty conservative.
Okay, and then I'll stick on that same thread around the budget wise, and I know we're looking at the up to 26, 27, and is there in anticipation of, I know we've talked about this being a pilot, and looking at a 3-year piece, and it's like all this work and time and effort being put into something that then in 3 years comes back and it's like, hey, we need millions of dollars to have this be sustainable moving forward, and if the economic picture globally changes and cities don't have it, and all of a sudden this service that people are used to and the cities are used to and our police departments are used to, all of a sudden has to go away because there's not money there. Are there anticipated new revenue streams after the 3 years that's not so dependent upon the cities to be able to fund the gap if that happens?
I think the unfortunate reality of that is probably no. I think Prop 1, frankly, is going to be bad for crisis now, and it's going to be bad for the county to some extent with MHSA funding, which funds a great deal of this. I think we are seeing a decline in kind of those open revenues that are coming to counties. The bright side, though, is DHCS is mandating many more requirements of this sort. I wouldn't be surprised if they are mandating receiving centers and some of the things that are a few years out. Our goal, though, is to build revenue. So our goal is to launch the program and really get good at building revenue. Again, Carly talked about building private insurance. It's not really feasible today for any county, but it's moving more into that space. The revenue projections so far that we've gotten just for Medi-Cal recipients is promising. The state has proposed a pretty fair rate. So our goal is not just to build a program that makes everybody love it, it's to build a program that can financially mostly support itself. But I do anticipate there may be some gaps in the future. Again, none of us really saw Prop 1 coming, and so who knows what will happen based on this, that, or the other. But right now, I'm a little nervous just based on what's happening politically. However, DHCS is continuing to move into the space and to some extent continuing to provide revenues, which has been helpful. So that's a big push for us too.
Yeah.
Sorry, just
Sorry, yeah, no,
to add, and I agree with Nolan, and in a maybe slightly optimistic perspective, I think that a significant priority of the county in the early stages of this pilot will be to maximize the revenue we're able to generate, particularly for the receiving center, but also to really build in infrastructure around our data sharing and analysis to be able to quantify the savings to our hospital systems and also to our local law enforcement partners, right? If we're reducing wall time in the EDs or and really looking at what kind of cost savings is being experienced at the front door of our local hospital systems. These commitments from our local hospital partners have been through their community benefit funds, which are intended to be short-term, one-time, to stand up infrastructure. We believe that there is likely a compelling story over the long haul about the cost savings experienced and maybe ongoing investments from some of our other partners outside of the cities. But we are going to have to ensure that we're building the right infrastructure around data sharing and analysis to really bring some dollars to that suspicion, right? The suspicion is not enough. So that's one of the tasks for us.
Yeah, thank you. That was my next line of questioning was just around, when you look at the numbers for Dignity and Sutter, if there have, it's low, and if there have been conversations around, with them, or if models like this have happened in other jurisdictions or other states where they've been able to really put the data out there to show to hospitals that there is this cost savings, and if there's been conversations with those groups to say, you can't get those promises now because we don't know, but has that line of communication been opened, that the door could be open to that if there's significant savings that they would be willing to come back to the table?
Yes, and I think that's absolutely possible. I'm so glad Carly added that because that is a big assumption of the pilot that we think will come to fruition.
That's good, yeah.
And so the original pilot, honestly, shows a dramatic reduction in the use of emergency rooms. It shows dramatic reduction in wall times. That is the big selling point of the crisis now model in general. Dignity and Sutter have been early adopters, super confident from the beginning, and again, like Carly mentioned, they use their community funding, not their other pots of funding. So we fully anticipate that as soon as we have some data to show, we'll be going back to them, and they know we're going to come back, and I think they're very excited for this pilot too. They're being responsible and being a bit skeptical, which we don't blame them for doing, but that is absolutely the first conversation we'll be having, probably not even at the end of the 3 years, probably at the end of the first year or second year, as we start having some data to come back to those folks and show them.
Yeah, I think that's great, and I think the other piece, I know we talked, I think Nolan, you mentioned it earlier, there's a big glaring gap under one of our partners here with nothing in it, and I think we've talked about this in our previous 2x2 around interacting, engaging in conversations with UC Davis, and how do we, as elected officials in this community, maybe start that conversation with them or get some meetings together and try to bring them to the table with some of this. I think that's another big part of of what we need to do in terms of next steps moving forward, because we do know that there's a large population of our community, especially here in Davis, that would be utilizing this service that are connected to or folks at the university, so I think we can further that there. The last thing I have, and I'll be quiet for a minute, is just the question around like mental health chairs and sobering chairs, and like how we distinguish those two, right? And that they're not seen as one. I think folks in different communities look at it, convoluting those is an issue for folks. I think bifurcating them and being clear on what the purpose of those two are would be an important piece as well.
Great point. Great. Do you want to add?
I'll just say that the intent is really for the receiving center to be able to handle any behavioral health crisis, and so that would include someone who's having a substance use disorder crisis or a mental health or both, and lots of things for us to work through infrastructure-wise around the sobering center idea and the requirements in terms of medical attention and other needs required in that kind of a model. This is not a crisis stabilization unit, which is a very different licensure category, and that's a nuance, but it's a state licensing category for a facility. So really the intent here is for it to be a receiving center. Folks can stay for up to 23 hours, but lots of work for us to do around the model, and we're concurrently working on the RFP that we'll be putting out for the operation, so the operator would be a close partner to us in helping develop some of that.
Thank you for that. Appreciate that back and forth and all the answers from staff. Supervisor Friends, anything you want to add in? And I've got a couple thoughts too.
Oh, sure. Thank you for your presentation on the work you're doing on this. It's fantastic. One of the problems we have is how compartmentalized every budget is. So you may be generating a tremendous savings for somebody else, but then convincing them to come in, whether it's a hospital or a different county department, it is a big chore, and it might not work. So I'm wondering whether you, and through your various associations, are considering legislation that might require some shift in funding if you can demonstrate a cut in costs for the hospitals, because really they're not doing much right now. This community funding they're giving, they're mandated by federal law to give, so they're not really giving anything. And I want to be optimistic too, but I think backing that up, we might need to look at state legislation.
Yeah, I think it's a great idea, and more counties are starting to move into some form of crisis space. If you've seen one county, though, you've seen one county, right? So I think we certainly could approach our local CDHDA or CWDA to start talking about kind of working with the HCS on some legislation to continue to fund some of these expanded functions. Like I said, DHCS, as much as they drive me crazy, they have been really forward-thinking in some of these spaces, and they continue to push things in this space too. So I think they would be very willing partners, especially if we had some data to show in this arena. So I'm confident that folks will be impressed if the numbers are there. But to your point, and it's a great suggestion, we certainly can approach our two associations.
And just to add that there is some pending legislation to implement locally, Senate Bill 43, which changes the criteria for conservatorship, for LPS conservatorship. The California Hospitals Association was a proponent of the bill, although they are very worried about impacts to their emergency departments, and so our local hospitals have been on board with our board's decision to defer implementation, and we'll be working closely with them in a work group to develop that process. And the reason I bring it up here is because it does have direct impacts on this model that we're proposing here. So I think that will be another platform or opportunity for us to engage in very specific conversations with our hospital partners around the reduction of visits to the ED and about why this model is going to be critical in that process.
Great, thank you.
Yeah, thanks very much for that, Supervisor. I appreciate you raising that point about the potential sort of need for some adjustments at the state about on this issue. I think that does make a lot of sense over the course of the next couple of years. A couple quick things. One, just, well, very grateful to the city, all the cities, but particularly the city of Davis for sort of already, the other cities haven't officially allocated those dollars sort of already, and the city of Davis sort of, set aside those dollars, a couple years ago, and have consistently been keeping them sort of earmarked for this. While all those dollars add up, the county is, also still, committing $7.5 million for the sort of overall sort of the next couple of years, and I think that some, of course shows the county's commitment to this issue, but I think that the points that were raised around, sort of the proof of concept issues with the medical, or the health systems, I think that makes a lot of sense. They've got to sort of see a little bit of a, proof of concept here, so I'm sure that we'll see, there'll be an ability to help see more dollars from them over the course of the next couple of years, especially as we get going. And then also, yes, the issue around the campus, we had that discussion with them at the sort of city, county, university, meeting in this room back in, I think it was November, or maybe just early December. And honestly, I think if the city's willing, which I assume so, but, the city and the county being willing to approach the campus, I think together, on this issue, around we heard about, Health 34, their van, and the sort of mobile van they've got. I'm not sure what the official, I think that's what it's called, and that programming. But I think, it would be also helpful to know I don't know if we know these details right now, but it would be helpful to know before sort of going to the university to sort of get a sense of the calls that are actually originating from the university, or I know maybe there's protections around sort of HIPAA, sort of information and such, but knowing what if there are indeed a number of students or utilizing or campus affiliation, something along those lines. So it could be, professors, it could be, faculty, it could be staff, whatever. I assume some of those calls already, so out of 50, but, I assume we've got to have some sort of data around where calls are originating from, and such, so that's the question. I think it actually also speaks to the other issue around, I understand the per capita sort of funding, and so a larger city is tasked with providing additional dollars, but I think as we get this program rolled out over the course of the next couple of years, it would be really good to know where the calls are sort of originating from. I don't know that, while the city of Davis is being expected to put a larger percentage of dollars into the overall funding pot because of its population, I don't know that it will have more or less calls than another smaller jurisdiction that is putting less dollars in. So we'll be curious about that as we sort of get into the process as well too. So both for the university and also for the sort of the different sort of usages around different jurisdictions. So those are a couple of my thoughts.
Yes, and we will have that level of data available. I don't have it with me today. I wanted to circle back just quickly just to let you know that there is some pending legislation that's been drafted by Assemblymember Jesse Gabriel, AB 2700, which is seeking to increase access to behavioral health treatment locations other than emergency rooms, like crisis stabilization units and sobering centers. So I think there is something already in the works, and so I think that's a bill to watch, and certainly depending on the details of it to perhaps support as it's moving through the legislative process.
Thanks for that update, Carly, appreciate it. Additional questions or comments, especially from anybody on this particular topic, and then we also go to public comment. Yeah, go ahead, Carly.
Yeah, I think that when we're talking about the per capita, it sort of supports UC Davis putting in some money.
Totally.
Because our population is increased by the number of students.
Yeah. I put a carve out exactly in that table for that comment. I totally hear you. Davis's population is such a large, so I think that's a great place to start with them. And again, I'm more than happy to come bring materials and descriptions, and I'd love to have them be a contributor as well.
Okay.
Thank you for that, Corey. Sort of turn it over to the staff. It seemed like Mike had some comments.
First of all, I want to express from a staff perspective, express our appreciation to Gerardo and Nolan and their staff team in putting together these materials. We did have, just a couple weeks ago, a really constructive, very productive, what we call our Yolo managers meeting, which is all the city managers and the CAO. We get together on a regular basis to talk about, core issues that are of mutual interest. And Crisis Now is very high on that list of our common interests amongst the city. So we had a very constructive conversation, and I appreciate Gerardo and Nolan coming to that. We had a very similar presentation to the one that Nolan provided to you today. We got sort of our questions, our clarifications out on the table, most of which have been responded to and answered here. I think in terms of the funding approach to it, I think there was a general consensus that at least starting with a population-based approach is as good a place as any to start, especially when it's a new program and we don't know where the population served is going to exactly come from. I think there's interest in revisiting that over time as the program rolls out. And there's other models of that with JPAs and so forth that we've looked at over the years that are similar, where we have mutual services. And then we also had some conversation about the ARP funding commitments of the city of Davis, and just talking through the logistics of that to make sure that we stay on the appropriate timeframes for the spending of those funds or the encumbering of those dollars. Gerardo is committed to, we're going to do some follow-up internally with our finance teams to make sure that we're in alignment, because there are clocks that are ticking with respect to ARP funds, and we just want to make sure we don't get in arrears of the timing issues. For programs, it's basically the end of this calendar year is the deadline to have funds out the door. But for capital improvements, it's 2026 is the deadline. And so there may be some options there, particularly if the ARP funds are going through the receiving center, which could be considered a capital improvement project, that may give some flexibility in the timing. I will be engaging, I think, with our council about the ARP fund commitment. Obviously, the city of Davis has made a strong commitment in terms of our contribution on ARP funds. There may be the delta there between the 1.17 and the 930 that's being requested, just because of those time sensitivities around the ARP funds. I'll probably be approaching our council to at least have a conversation around that slight difference. Certainly there are other needs that we could identify to invest that delta, but we would have to obviously do it in a timely manner to stay in keeping with the ARP timelines. So I'll be engaging with the mayor and city council members in that conversation. But I think what you're hearing pretty clearly here is that Davis is committed to our contribution and for the ask here. So I think that's about it from my standpoint. There is the LEAC meeting that's coming up that no one mentioned with the police chiefs and the law enforcement chiefs from the area this week, and Chief Pytel from our team has been very, very engaged and very much on top of this in terms of what's required by the law, all the changes. There's a lot of things that are in flux and changing as of January that we're all trying to wrap our arms around, and we do truly appreciate the partnership with the county to navigate all that. And the co-responder model, there is a commitment from the city council to do the second co-responder. We started with the city council funded the city's portion of the funding, which is about a third, as you mentioned, of the total funding for that second co-responder. And my understanding is that there's good progress being made on the hiring of the second co-responder. So that's fantastic news, and we have been very, very appreciative and supportive of that program, and our police department loves it. So, that's all I had. Thank you.
Just a couple of quick comments. First, I wanted to just publicly express my gratitude for Mike Webb's leadership on this. As he mentioned, we met with all the city managers. That meeting, in my opinion, went a lot smoother thanks to Mike's leadership. I think that him essentially reiterating the city of Davis's commitment has helped us with our other cities. So thank you for that. And just finally, this is a huge priority for my office, and so we're definitely going to be seeking some legislative alternatives over the coming couple of years to address all the points made here. Thank you. Oh, yes, thanks. Mike just reminded me. And so we've got a joint earmark request through both our members of the House of Representatives, Congressman Thompson and Congresswoman Matsui. So I believe, as I've been told, this is the first time in our county where anybody can remember all four cities and the county joining to make a joint earmark request. So that's phenomenal. So thank you. And again, can't thank Mike enough for his leadership on this, and Nolan and Carlene, thanks for doing all the lifting, heavy lifting on this.
Thank you. Appreciate all of those updates as well. Yes. think that it, I mean, you know, no, some of us have been around for longer than others, but it's like, I think, first time I've heard that this, sort of the unanimity of every, it's on. It's the first time I've heard that the unanimity of, you know, all the agencies in the county sort of being on the same page as it relates to earmark requests for our congressional members, so it is definitely a big deal. Public comment on this item, and we're gonna do that quickly, and then we'll get on to the last items of the day. Public comment on this item?
It wasn't a public comment, but it was a response to your question about the scope of Health 34. So that only serves people on campus, so it doesn't, and it's a non-emergency service explicitly, so.
Thank you very much, appreciate that. Yes, we had a presentation by Chief Charnick at that last meeting on the Health 34. Thank you for that reminder, appreciate that. Let's see. So communicate, item 7, Board of Supervisors, City Council Communications. It's also probably the same sort of item to just ask for future 2x2 items. We put out a call for items for today. We often want to spend a bunch of time on Crisis Now, since it's such a key importance to both agencies. But are there any other items, either in communications or future 2x2 items people want to see on the upcoming agenda?
Well,
Yeah.
the items that we had deferred, Pacifico housing, and the concept of including students on future housing discussions with University of California. And I'm wondering, since we only, and this, I'm very supportive of just having one topic today, it was really good. But I wonder if should we consider a meeting next month rather than waiting 2 months since we have those pending items?
I think that's probably could be an option, but I think it's all about scheduling. I mean, making sure that it's on folks' calendars. So I don't know if we want to just have a discussion, have the staff sort of just figure out if we can.
Yeah, so I have a suggestion there. So Mike and I and our teams, we're gonna huddle on Pacifico. We've got a little bit of staff work to do on that. We're doing that over the next few days. So if we make a little bit of progress there, we basically got some engineering issues that have come up and some building permit issues that have come up that we need to sort through. So I think if we can make a little bit of progress there, we can certainly work with everybody's calendar to see if we have something substantial, we can certainly come back in a month. I think we can probably make a lot of progress in the next few days and report back and then schedule as needed.
Okay, sounds good.
Great, thank you, appreciate that. Any other items there? Otherwise, we'll look at, so actually item 8 is actually just upcoming meeting dates. We may look at potential for April rather. But otherwise, we've got our sort of next set of dates. And any other items before us today? Otherwise,
I just wanted to thank City of Davis for being out the gates quickest on this, because it is really a new paradigm. Mental health was traditionally something that just counties and the state did, but it's a problem that's a lot bigger than us, and for Davis to recognize it, and when you were on the council and our current council members, that's a tremendous thing to do, and it is an example for others, and that's the only way we're going to solve these big problems, is to solve them together, city, county, state. But at the local level, the city and the county working together is a tremendous achievement.
appreciate that, and just especially just to the current members of the council, just this continued steadfast commitment on this, because especially seeing this now from a county perspective, I see this sort of I mean, I often thought it was a serious issue and serious concern, but like the Supervisor Perez's point, it has long been often just a county only kind of situation, and it's really so grateful to have the support and the leadership by the city. So thank you to the City of Davis especially. So, any other items at all, or any good for the order? Otherwise, we will stand adjourned and we will figure out our next meeting date, whether it is April or ultimately May. Thanks very much, everyone.
Thank you.
Thank you.
Good job.
Hopefully everything else is going smooth.